Catholic Physicians Guild of the Philippines Bioethics Lecture Series. We will start the program with a prayer to be followed by the Philippine National Anthem.
Let us bow our heads and put ourselves in the presence of the Lord. Dear Heavenly Father, we thank you for gathering all of us today. May you bestow your guidance and blessings so that we can enjoy and appreciate its significance in our lives. Bless everyone who are present here today, that each one of us may be able to share our knowledge, understanding, and wisdom for your glory and honor. May the various activities related to this event be a success through your intervention. We all ask of this in the mighty name of Jesus. Amen.
Bayang mabiliw, pelas ng sinanganan, alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyan ka ng magiging, sa manlulupig, di ka pasisingin, sa dagat at bundok, sa simoy at sa langit mong bakaw, may nilagang tulad namin sa paglayang minamahal, ang kisat ng watawat mo'y tagumpay na nagdidinig, ang bituin at araw niya kailan pa may di madidinig, lupa ng araw ng walhati pagsinta, buhay ay langit sa piling mo. Aming ligaya na pag may mga api, mamamatay ng dahil sa'yo.
Good day. I am Dr. Pacifico Eric E. Calderon, the National Treasurer of the Catholic Physicians Guild of the Philippines. I will be your host for this bioethics lecture series with the theme, Ethical End-of-Life Concern in Neonatal Care. Let us all hear from the President of the Catholic Physicians Guild of the Philippines, Dr. Ramon C. Severino, as he delivers his welcome address.
Good afternoon, friends. Let me welcome you again to the lecture series of the Catholic Physicians Guild of the Philippines. This would not have been possible if not for the hard work put on by Dr. Mike Resurrection and the committee on ethical modules. This lecture series actually has been going on. I think this is our third one, and then I hope everybody appreciates what the Catholic Physicians Guild is doing in terms of issues regarding ethics. Tonight, we have a special lecture on, we have three speakers to talk on neonatal concerns in end-of-life care. And this is very relevant in our practice, not only as pediatricians, but doctors who are practicing medicine, who could very well be an instrument of how we should approach patients in the neonatal period. We have invited guests who are authorities in the field of neonatology, lawyer, and of course, our spiritual advisor. Our speaker for tonight is an expert in the field of neonatology, and we'd like to thank Dr. Chato Corpus for accepting our invitation, and Dr. Albert Rebosa, and a lawyer also from the University of Santo Tomas, and of course our advisor. I'd also like to thank Doc Witty for recording and actually airing and the proceedings for tonight. So I hope you welcome. We also would like to welcome you to be members of the Catholic Physicians Guild. Hopefully you can be part of this prestigious organization whose objective is to bring us doctors and our patients closer to God. And also I'd like to thank our advisors who had been our inspiration through the years. Allow me to end my welcome to read this poem. It's a message of a father who lost his son and has a son and a daughter left. This message is for my baby boy. Just to send you all our love. Sadly, no longer you are here on earth. You're an angel up above. We will never forget you. You are you're our you're our thoughts of every day. The love we hold within our hearts never fades away. Your little brother and sister will always know you by name. Going on without you, life would not be the same. Rest peacefully with your family who has gone before. Watch over us always until we meet again once more. Again, welcome to the Catholic Physicians Guild lecture series and good night, everyone. Thank you.
Thank you, Dr. Ramon Severino. The Bioethics Lecture Series is a project of the Committee on Bioethics module shared by Dr. Michael M. Resurrection with members Dr. Sheila R. Yap and yours truly, Dr. Pacifico Eric E. Calderon. Let us all listen to Dr. Michael M. Resurrection as he gives the course overview.
Good day, everyone. This module aims to discuss the ethical consideration in end-of-life care with focus on NICU context. Identify the roles and duties of healthcare professionals in addressing the ethical issues. In this module, the clinical scenario will be discussed by our speakers. Dr. Charito D. Corpus, a neonatologist, will discuss the clinical aspect in end-of-life care of the newborn. Attorney Albert D. Rebosa will talk on the legal concern, and Reverend Father Rodel E. Aligan will delve on the spiritual concern in the end-of-life care of the newborn. The discussion will be followed by a live question and answer forum. Please answer the post-evaluation survey and post-test at the end of the course. Enjoy and learn much from this module. Thank you.
Thank you, Dr. Mike Resurrection. I have the pleasure to introduce our distinguished speakers. They will definitely inspire us as they share their thoughts on the ethical end-of-life concern in neonatal care. Our first lecturer is Dr. Charito D. Corpus. Dr. Corpus obtained her medical degree from the University of the East Ramon Magsaysay Medical Center and her Master in Hospital Administration degree from the Ateneo Graduate School of Business. She completed her residency in pediatrics at the Medical City and fellowship in neonatology at the Philippine Children's Medical Center. Currently, she is the division head of the Neonatal Intensive Care Unit within the Philippine Children's Medical Center. Ladies and gentlemen, let us welcome Dr. Charito D. Corpus. Our next speaker is Attorney Albert D. Rebosa. Attorney Rebosa obtained his medical degree from the University of Santo Tomas Faculty of Medicine and Surgery and Bachelor of Laws from San Beda College of Law. He is the Assistant Chair of the Department of Forensic and Legal Medicine at St. Luke's Medical Center, College of Medicine. He is also a medico-legal consultant in various hospitals in Metro Manila, and he has authored The Basics of Philippine Medical Jurisprudence and Ethics and Philippine Medical Jurisprudence textbooks. Ladies and gentlemen, let us welcome Attorney Albert D. Rebosa, MD. Our third speaker is Reverend Father Rodel E. Aligan, OP. He obtained his doctorate in Sacred Theology from the UST Faculty of Sacred Theology and his licentiate in Sacred Theology from the same faculty. He also completed Master of Arts in Higher Religious Studies at UST Graduate School, and currently he is Dean and Professor of the UST Faculty of Sacred Theology. Father Aligan is the Ecclesiastical Advisor of the Catholic Physicians Guild of the Philippines. Ladies and gentlemen, let us welcome Reverend Father Rodel E. Aligan, OP. We will now proceed to the reading of the clinical case scenario for ethical end-of-life concerns in neonatal care. So for our case, BBA was born full-term from a low-risk pregnancy via emergency CS for fetal distress. At birth, the baby was cyanotic, apneic, with a heart rate of 0. After 15 minutes of full resuscitation, the heart rate became 40, but still without spontaneous respiration. The baby was pale. The attending pediatrician apprised the maternal grandmother regarding the status of the baby and asked if resuscitation shall be continued. The reply was to do everything. The baby was brought to the NICU where full ventilatory support and 2 inotropes were required. The pupils were fixed and dilated. There was no spontaneous respiration noted. Therapeutic hypothermia was started. However, the desired outcomes were not seen. By the 48 hours of life, the baby was still on full ventilatory support and 2 inotropes. There was no urine output since birth. The pupils were dilated and no response to pain stimuli was noted. The mother and grandmother were apprised. They were ambivalent as to continuation of intensive care. The father, who is working overseas, expressed desire for aggressive measures. The family was informed that the medical team will confer with them daily. By day 5, multi-organ dysfunction has set in. The baby was still oliguric, neurologic status has not improved, there is no spontaneous respiration noted. The possibility of a need for peritoneal dialysis was relayed to the family. They were informed that together with the pediatric neurologist, the baby's neurologic status will be reassessed by day 7. If criteria for brain death are met, withdrawal of life support will be recommended. The mother agreed to these plans. However, the father insisted that full support be continued.
Good evening. I would like to thank the Catholic Physicians Guild of the Philippines for this invitation. I am looking forward to learning from our other panelists, Father Aligan and Attorney Rebosa. The following slides will contain material from recent references cited accordingly and will serve as take-off points for further discussion. The case to be discussed is hypothetical, and any similarity with previous actual cases or patients is not intentional. The recommendations made will not be entirely prescriptive for other similar cases, as each case has peculiar circumstances. To even see the words death and dying and beginning of life on the same page or slide is strange in itself. And to accompany parents during an actual clinical scenario is a most difficult but necessary challenge to face. How do parents face end of life of their child soon after birth when they had everything planned for a perfect baby? Such extremely emotional situations do not at all facilitate decision-making when needed most. Necessarily, the healthcare team acknowledges this difficulty and have to face their own questions while trying their very best to accompany the distressed parents as they start to grieve for the loss of that perfect baby they had in mind even before that life approaches its end. The decisions to withhold or withdraw life-sustaining medical treatment are usually based on one of 3 general criteria. And the first being the identification of inevitability of death. When infants are very likely to die in the NICU, regardless of whether life-sustaining treatment is continued, life-sustaining treatments that serve only to delay the moment of death need not be continued. However, us clinicians should recognize the difficulty in predicting outcomes with certainty, as studies suggest that in many circumstances, neither clinical intuition nor objective scoring systems are reliably able to predict mortality in critically ill neonates. And in addition, while additional hours or days of survival might not ultimately change the outcome for the infant, this time will be highly valued by the family, either as a good unto itself or as an opportunity to gather friends, to be with their baby. And the other general criteria are ineffective treatment and the likelihood of poor quality of life. We have here the general categories of clinical scenarios wherein end of life care are considered. And for the first group, we have life-threatening conditions for which curative treatment may be feasible but can fail. And examples will include extreme prematurity, severe necrotizing encephalitis, and critical congenital heart disease. Secondly, we have conditions where premature death is inevitable, and these include some chromosomal abnormalities, bilateral multicystic dysplastic kidneys, or bilateral renal agenesis. Third group are progressive conditions without curative treatment options, where treatment is exclusively palliative and may commonly extend over many years. Examples of these are skeletal dysplasia and severe neuromuscular disorders. The fourth group constitutes irreversible but non-progressive conditions causing severe disability, leading to susceptibility to health complications and likelihood of premature death. And these include severe hypoxic ischemic encephalopathy, especially so if this is accompanied by multi-organ dysfunction, as we will see in our case. Necessarily, we mentioned the basic ethical principles in healthcare by Beauchamp and Childress. First, autonomy, or in the pediatric age group, we refer to this as parental authority. During the 20th century, there is notable shift from paternalistic or information sharing to parent empowerment. Finding the right balance between respect for parental autonomy or authority and the very important physician's role and responsibility in any decision-making process requires insight, empathy, and great analytical and communication skills. Beneficence is the obligation to do good, that is, to promote the best interests of patients. And in newborns, this obligation is embodied in the concept of the best interests of the newborn. Non-maleficence is a distinct principle and requires intentionally refraining from actions that cause harm. It requires that no initiation or continuation of treatment be considered without consideration of whether the treatment is overly burdensome or harmful. And fourth, justice. This is the framework by which we determine how social benefits, such as healthcare, and burdens, such as research risks, are distributed, and considerations of macro as well as micro allocation resources are made. It would be very simple if one and all of these principles are applied in each case, but in some cases, there is an apparent contradiction in one or two of these principles, but they are necessary or essential principles by which we base our decisions. Here we have a list of key concepts underlying ethical care in the NICU. We already talked about the best interest of the infant standard of judgment, minimizing harm to the newborn, respecting parental authority, which leads to developing sound parent and physician relationships, empowering and informing parents, applying family-centered care principles, and respecting the parents' values and cultural and religious beliefs. And So we have the byword now as shared decision making. On top of this, we always are mindful of having respectful interprofessional teamwork, moral teamwork at that. Our Philippine Pediatric Society includes in its Code of Ethics of 2020 a section on neonatal care. And as most publications indicate, half of this refer to initiation versus non-initiation of resuscitation, decision-making at the peri-viable ages of gestation. But it does include an important element wherein it is indicated that the decision on subsequent management shall depend upon the assessment of the following. Aside from viability, any comorbid conditions, confirmed lethal anomalies, chances of survival, availability of health resources, and risks of mortality and morbidity. And again, the importance of updating or discussing these with the parents and our legal guardians during a family conference, properly documented at that, is indicated. And all decisions reached shall be relayed to all concerned healthcare providers. The same principles underlie the guidelines that were formulated in this local publication, co-authored by the now President of the Philippine Society of Newborn Medicine, Dr. Esterlita Uy. Decision-making around resuscitation of extremely preterm infants in the Philippines. While this is for the extremely low birth infants, the same principles may be applied in other clinical scenarios in the NICU. And what are these? Again, best interests of the child should be the primary consideration in decision making. As to family involvement, the child and the family should be always considered together. And in the shared decision-making model, the healthcare team has to consider that such has to be values-based. This means that what the healthcare team defines as good versus bad outcomes may be quite different from what the parents perceive to be good or bad. For example, they may consider moderate impairment or quote-unquote died while trying or any survival as actually good outcome for them. In considering withdrawing or withholding treatment, it is ethical to withhold resuscitation from a newborn if that treatment would not be in his or her best interest. And especially so if it would impose an unreasonable burden on the child or the family or would constitute an unreasonable use of limited resources. There is no ethical obligation to provide or continue treatments that are unduly burdensome, extraordinary, or disproportionate. So we go to the case for discussion this evening. Baby A is a full term from a low-risk pregnancy and was delivered via emergency cesarean section due to fetal distress. The baby was delivered cyanotic, apneic, and heart rate 0. After 15 minutes of full resuscitation, the heart rate remained 40 with still no spontaneous respiration and was pale in color. The attending pediatrician apprised the maternal grandmother regarding the status of the baby and asked if resuscitation shall be continued. The reply was to do everything, as we often hear. This clinical scenario is one of the most difficult and emotion-laden for all parties, as the outcome was not at all anticipated, even if the indication for the cesarean section was fetal distress. The first conversation between the doctor attending the delivery with a companion or relative, and in this case, the grandmother, is crucial and necessarily truthful. We will have to understand that the grandmother was there only as a companion and was not prepared to be a major decision maker. At the earliest opportune time, without compromising the conduct of resuscitation, the attending has to inform the family that the baby is not responding to full aggressive resuscitation. She will assure the family that full resuscitation will be continued, and then the family will be apprised of response to such resuscitation after 10-15 minutes. The question here of shall we continue resuscitation cannot be processed by the grandmother at the time, and to have asked it was not necessary and inopportune. Having done so, the attending will have to assure that yes, everything is actually being done, everything medically possible as per standard, and we will continue to do so. And we will let you know if the response of the baby is not optimal. In this article, it is indicated that when in the delivery room, when one is at a crossroads with a poor environment for decision making, such as in this case, the better option is not apparent. The wisest and most ethical justifiable choice is commonly the path more easily reversed. So we tend to opt to treat in these situations. A decision to attempt resuscitation in the delivery room does not ethically commit one to continue all active measures, including future attempts at resuscitation. The parents acting as surrogate decision makers on the baby's behalf have both a right, though we have to emphasize this is within some constraints, and an obligation to decide on her behalf based in large part on their assessment of her best interest. And we continue. The baby was brought to the NICU where full ventilator support and 2 inotropes were required to maintain minimum blood pressure. Pupils were fixed and dilated. No spontaneous respiration was noted. Therapeutic hypothermia was instituted. However, the desired outcomes were not seen. So after the initial conversation, the grandmother is apprised of the baby's condition. It is important that from the very start, the attending comes through as truthful and sincere. Even more importantly, as being competent. A trusting relationship from the start facilitates subsequent decision making. We have here the general guidelines for respectful communication with parents in the NICU. First is the environment, but in this case, during the first and even second conversations, the environment was not at all the ideal environment for that conversation. But we have to emphasize this continuing communication with parents at the time of admission, at any crisis point in their child's NICU course, and via periodic reviews of longer stay patients and other unstructured opportunities. We provide open, truthful communication at all times, and we provide information as accurately as possible and with as much certainty of diagnosis and prognosis as is possible in each clinical situation. And we do have to recognize the need for the parents for time to process and absorb information. Oftentimes, we need to repeatedly summarize for them the medical findings and plans of management for the baby. By 48 hours of life, the baby was still on full ventilatory support and 2 inotropes. No urine output was noted. Pupils remained dilated with no response to pain stimuli. The mother and the grandmother were apprised. They were ambivalent as to continuation of intensive care. The father, who works overseas, expressed desire for aggressive measures. The family was informed that the medical team will confer with them daily. During this time, the mother shall be encouraged to spend as much time as possible at the baby's bedside. Periodically, the attending validates what she understands to be her baby's condition and likelihood of survival and beyond the NICU. She is consistently assured that she will be informed of any changes in her baby's condition, including response or poor response to ongoing management. Many times, the attending needs to clarify the expected improvements and goals of management after another 48 hours. And it would be good to arrange for a virtual meeting among parents and at least 3 other stakeholders, maybe the grandparents, any family member who is likewise a healthcare worker, and even their spiritual director. The present plans to confer with other health specialists if additional problems arise should also be relayed, and these family conferences have to be properly documented. By day 5, multi-organ dysfunction has set in. The baby's oliguric and neurologic status has not improved. No spontaneous respirations were noted. The possibility of a need for peritoneal dialysis was relayed to the family. They were informed that, together with a pediatric neurologist, the baby's neurologic status will be reassessed by day 7 or after another 48 hours. And if the criteria for brain death are met, withdrawal of life support will be recommended. The mother agreed to these plans. However, the father insisted that full support be continued. So even before conferring with the family, a multidisciplinary care team meeting should have been held, and each diagnostic and therapeutic intervention recommended are discussed as regards benefit versus harm from each. Questions among healthcare workers and even the family will arise around this time. Are we doing too much? Are we doing too little? Are we doing these interventions to or for this child? During the family conference, the medical status is summarized and the benefits and harms of further interventions are discussed. The possibility of irreversibility of organ dysfunction is elucidated. Even the possibility of eventual cardiac failure despite ongoing inotopes should be considered, and the benefit and non-benefit of cardiopulmonary resuscitation is presented. All throughout these discussions, you will have to recognize, though, that some parents would rather not hear too much medical information and will also want to hear what the attending recommends. At times, the more they hear, the less they understand. It has been noted that warmth and trustworthiness from the attending physician are what impress parents first, followed by intelligence and wisdom. And again, when a mutual trust relationship is established, shared decision-making is facilitated. It has been noted that parents or families prefer to participate to some degree in these decisions, but most do want to hear what the physician recommends and then still have the option to follow or decline those recommendations. We have here a basic framework for collaborative end-of-life decision-making. And first, again, is setting up or creating an optimal environment for discussion. We try to establish that the presenting issue is an ethical problem, one in which moral values conflict or moral uncertainty exists. We identify the decision makers. Most often than not, these are the parents. Establish the relevant facts. As has been said, good ethics always begins with good facts. Explore the options. Explicit discussion of treatment options and their known potential consequences should occur. Try your very best to develop consensus. All decision makers should be in agreement with the plan of action proposed at the time, even though occasionally agreement may be a temporizing measure. And then implement the decision. How do we go about this? More recently, we formulate a physician or medical order for life-sustaining treatment. We no longer use the term DNR form or DNAR form, so that it now refers to what we continue to do for the patient. These forms were created to provide a more encompassing medical order, not just at the event of pulselessness or absence of respiratory effort. It is an opportune time to discuss any redirection or shift in the direction of care for the patient. It may still include the terms DNAR or do not intubate, but more recently now, the term allowing natural death is proposed, and this is indicated in this form. In this form, the clinician should clarify which resuscitative efforts should and should not be attempted. We complete a medical order so that the entire team knows how to respond, and we document the discussion in the record. It is worth reiterating that even when CPR limitation orders are in place, clinicians must still address the role of other medical evaluations and treatments with patients and families. And this will also include high-quality palliative care or comfort care. How about when conflict is sensed or even noted, as in this case, between the mother and the father? It's always good to allow time for further clinical observation and time for the parents and the father, in this case, to have a better comprehension of the medical information. And we continue to discuss, explore, and challenge the underlying reasons for the difference in choices. And we continue to negotiate or, facilitate for them to reach a consensus. And we try to broaden the parents' moral community, encourage them to confer also with the community. Oftentimes that will also include a spiritual director. For the physician's part, it is good that the moral load is ameliorated by seeking also opinions from other colleagues. And let's not forget the importance of consultation from the bioethics committee. Rarely do we need to transfer responsibility of care of the infant, and rarely do we go to legal measures to resolve such conflicts. The judgments or the options should be presented in a non-judgmental fashion, and we let the parents know that good, loving parents can and have chosen either way. They should be assured by the physician that he or she would never give them any options that are not ethically acceptable or reasonable for their child, and offer the opportunity to have others, such as grandparents or a religious advisor, to be involved in the discussion. In this case, given the clinical observations that the patient has no spontaneous respiration, one could be reasonably confident that the child would die eventually without the ventilator. And this should be stated clearly, but always with the acknowledgement that one cannot be certain of the timing of that demise. And these orders of life-sustaining measures will not preclude consideration. Literally, if the parents decide 5 minutes after they sign the form that they change their minds, then we allow them, we assure them that we will respect their wishes. The ethical obligations of the staff extend beyond the baby to include supporting the psychological well-being of parents. And as experienced clinicians, we are aware that the words that we choose throughout a baby's time in the NICU might stay with bereaved parents, possibly for the remainder of their lives. We do recognize that many patients and families lean heavily on their spirituality and faith at the end of life. and hospital chaplains and their families' spiritual supports can be engaged to provide support in prayer or religious rituals and to enhance clinical integration of spiritual perspectives. Often, arranging for baptism by a priest or blessing by a pastor of choice confers so much comfort to the family when they need it most. At the end of the day, this is what is expected of each one of us, is to do our very best to provide competent, ethical, and compassionate care. And we give due respect to the parents' family by acknowledging their difficulties, hopes, fears, and values as care decisions have to be made. And we recognize that many times the best way to accompany them is first and foremost simply listen. And when necessary, and this is often necessary, to pray with them. Thank you very much for your kind attention, and we look forward to the discussion of the other panelists.
Have a good day to everyone. For the officers and members of the Board of Trustees of the Catholic Physicians Guild of the Philippines, thank you for inviting me as one of your speakers for this bioethics lecture with the title Ethical End of Life Concerns in Neonatal Care. I was asked to deliver my lecture insofar as the legal implications of these ethical end of life concerns in neonatal care. And take a look at the title itself. There's actually no legal. The word legal is not present. Okay, but then again, the legal implications for all these ethical end of life concerns is always intertwined with each other. In fact, you've always heard of the saying, what is ethical may not necessarily be legal, and vice versa. But take note that what is ethical or moral is worth legalizing. Now, for the case that I was provided, this is more important because the patient involved is a minor. So the minor, having not in possession of that capacity to act for himself or herself, meaning to say he has no legal capacity, no juridical capacity. So the decision for this minor is passed upon to the nearest of kin. Okay. Now, under this, when we say ethical, it is the principle of doing what is right and not doing what is wrong. But when we say legal, it is doing what we are supposed to do, whether it's ethical or moral. In fact, they say that if you want a better world to live in, with all due respect to the legal profession, you might as well not involve us in any of these ethical concerns. But we have to take into consideration, it's a fact that in our practice as doctors, whether we are ethical or not, legal implications is always present, especially for end-of-life concerns. Okay, let us dissect the salient facts of the case provided. We have here a born full-term, low-risk via emergency cesarean section. So at birth, baby was cyanotic, okay, with a heart rate of 0. Meaning to say, pwedeng diretso sana siya mamatay. But after 15 minutes of full resuscitation, there was heart rate of 40, spontaneous respiration. Baby was brought to the NICU with full ventilatory support. Take note, full ventilatory support on inotropes, and pupils were fixed and dilated and no spontaneous respiration. And as doctors, we all know the prognosis of this patient. But the maternal grandmother here provided the consent at that moment to do everything. So we are now in a dilemma. Itutuloy ba natin to or hindi? But the person who gave the consent, who is the maternal grandmother, because presumably at this point in time, na CS yung patient, so patient may still be unconscious. So it was the maternal grandmother who provided the consent to do everything to this patient. Now, by 48 hours of life, still the same, no? Pupils dilated, no response to pain stimuli, still on full ventilatory support and inotropes. Day 5, there's already now multi-organ dysfunction. Still no spontaneous respiration noted, still on full ventilatory support, and now the need for other means for the patient to survive, which is a peritoneal dialysis. What complicated things here, at least legally, is the father is not present because he is working overseas, but expressed desire for aggressive measures. So that's the dilemma now. As doctors, we know the prognosis of this patient. The father expressed desire for aggressive measures. Day 7, they were informed that by day 7, by a pediatric neurologist, the baby will be reassessed. And if the criteria for brain death are met, then withdrawal of life support will be recommended. Take note, recommended only. Now, the mother agreed to these plans. But take note that the father insisted that full support be continued. So we now have contrasting consent. The father, full support will be continued. The mother, withdrawal of life after day 7, if that is recommended by the doctors. Now, what are the factors we have to consider? So I'm always trying to tell you time and again is the consent. What is the chance for recovery? The doctors will have to explain this to the patient. Substantial disclosure of facts. Again, you have to tell to the parents of this patient, this neonate, what would be the possibilities. A referral to bioethics committee. What are the existing laws that will apply to this case? And take note of this. Is there a civil personality now of the neonate? And what would be the legal implications if we will follow the mother or we will follow the father? Okay. Ethically, this can be resolved when they are referred to bioethics committee and a common consent is secured. Okay, but then again, with the facts of the case provided, there is conflicting consent from both the father and the mother. Now, what are the laws that can apply to this case? Take note that Article 40 of the Civil Code of the Philippines, birth determines personality. Why is this very important? Okay, civil personality is provided to a person when a conceived child shall be considered born for all purposes that are favorable to it, provided it will be born later with the conditions specified in the following article, which is Article 41. Take note of this. We have a neonate, we have a full-term baby delivered, presumably alive because the baby was resuscitated. Okay, so that baby, for civil purposes, the fetus is considered born if it is alive at the time of death. At the time of it is completely delivered from the mother's womb. However, if the fetus had an intrauterine life of less than 7 months and it dies within 24 hours after complete delivery from the maternal womb, then it is deemed not born, meaning to say no personality. Because civil personality under Article 42 is distinguished by death. Extinguished, sorry, there's a typographical error. Civil personality is extinguished by death. Now, the effect of death upon the rights and obligations of the deceased is determined by law, by contract, or by will. So what am I trying to tell you? Usually, this is very important, especially for the very rich people. By culture, when a woman is pregnant, the maternal grandparents, maternal and paternal grandparents will donate to this baby. So the baby is still in the womb. There's already a donation. Now that donation will come into effect if the baby is born alive with a civil personality pursuant to Article 41 and 42. So most often than not, no, especially for preterm, fortunately for this baby, it's full term. They try to have the baby to keep the baby alive, to comply with the requirements of having a civil personality pursuant to Article 41. What do we mean with this? If a baby is delivered less than 7 months and the baby died, so it's not considered born for legal purposes, baby will not have any legal personality or civil personality, then the donation now will not come to fruition. So ibig sabihin, if I donate to my grandson and my that grandson did not comply with the civil personality of the civil code requirements, then the donation will not come into effect. However, if there is a civil personality the requirements are complied with, even if the baby die after 48 hours, okay, at 24 hours, then that donation will take into effect. Short of saying that donation now, since the baby is dead after 24 hours, it will go to the parents. So you see this the ramifications of these donations provided so that they keep the baby alive, so that the donation will take into effect, because civil personality will there will now be a civil personality for this baby. So very, very important is the term, whether it's a preterm or term at the time of delivery. Now, take also into consideration the possible crimes that can be committed. Infanticide, if you kill the baby less than 3 days, it will not apply this case. Murder, reckless imprudence. Now, why did I say reckless imprudence? The father insisted that full support, aggressive measures will be done. What if the doctor did not comply with the standard of care to allow the baby to die? Then that doctor can be liable for reckless imprudence resulting to homicide. Worst is murder. While definitely it would be very difficult that a murder case will be filed against the doctors or the maternal grandparents or parents, I have one case to tell you. But this is not a case of a neonate, but it would be very important for you to understand why consent is very, very important. A female patient who was on vacation here in our country became critically ill. The husband, who is a British, was not present. So it was the mother of the patient who consented that to stop all means to support the daughter, meaning to say he asked the doctors that if they can now pull out the ventilator. The mother signed the consent. The doctor ordered, with all the consent provided, an explanation given to the mother. So to cut the long story short here, ventilator was taken out, the daughter or the patient died, and during the wake, lo and behold, the British husband came home and filed a case of murder against the mother, the doctors, the residents, and the nurses. Okay. The cases, the complaint for murder against the resident, the consultant, and the nurse were all dismissed, but the mother, a crime for murder was filed against her, and murder is an unbailable offense. Why? Because it was the mother who pulled out the plug of the ventilator, and the mother, according to the British national, pursuant to Philippine laws, he is the one supposed to give the consent, and the mother is not the nearest of kin. So you get the picture. Naawa na nga yung mommy, di na niya kaya, financially drained, spiritually drained, emotionally drained, physically exhausted, and yet he was sued for the crime of murder and languished in jail because murder is non-bailable. Well, fortunately for the mother, this case was dismissed against her, and she was able to file a bail for, I think, 500,000 just to have that temporary liberty. Okay. Now, with regard to the bioethical issues, I will leave this to the ethicists to explain it further. The principle of autonomy, beneficence, and veracity. Likewise, the principle of proportionality, which will really apply in this case. Is it still proportionate, or it's already disproportionate for this baby to be given continuous medication to support the life of the baby, because that is the consent of the father. Now, the right to consent to treatment. Take note that the patient is the final arbiter of his own body. We have here a neonate whose right to give consent is passed upon to another person, who are the parents. Now, on a legal point of view versus the bioethical point of view now, this is where I will come in, as I've mentioned or explained a while ago, a case regarding that murder. Okay. You may be ethical in doing so, but is it legally possible without incurring any sanctions or penalties or liabilities, so to speak? Now, take note that there are two legal requisites of a valid consent: age of majority and of sound mind. So the age of majority, please, it's no longer 21. Since 1988, during the time of then President Cory Aquino, the age of majority was from 21 to 18. Okay. We have now a neonate who is, of course, a minor and definitely not of sound mind. When you say of sound mind, the patient is conscious, coherent. Okay. On top of these legal requisites by law, now we have our ethical requisites for this valid consent, meaning to say there should be an informed and enlightened consent. It has been explained to the patient, the pros and cons, second opinion, what would happen, prognosis, morbidity, how much would it cost, things, necessary for us to get an informed consent. And it should be voluntary and the subject matter must be legal. Okay. Now you will ask, is it legal to consent to remove the ventilator or to remove all these disproportionate means? Okay. It is it would come to mind the word euthanasia. But take note, there are two types of euthanasia: active euthanasia and passive euthanasia. Active euthanasia is you kill the patient, or in other words, that's mercy killing. As doctors, what we provide is passive euthanasia. We allow the patient to die a natural death. Okay? We are not killing the patient. Now, what is the order for securing consent? The patient himself, the next in line, this is in order. The next in line is the spouse, then the descendants or children, then the ascendants or the parents or grandparents, then the collaterals or siblings, the nearest of kin, a legally appointed guardian, and if there's no one else to give the consent, the state or the government will have to provide the consent. Take note here that the patient cannot give the consent, definitely no spouse, no descendant or children. So we go to ascendants who are the parents. So the parents will have to provide the consent here. Unfortunately, two parents are present, the mother and the father, with conflicting consent or views. Yeah. So the doctor now here will have that dilemma. Who to, what do you call this? Sino ang paninindigan ko or susundin ko? Okay. Will it be the mother who would like to have the stop everything, or the father with the full aggressive measures? Okay. Unfortunately, under Article 3311 of the new Civil Code of the Philippines, the mother and the father jointly exercise parental authority over the legitimate children who are not emancipated. So jointly. However, in case of disagreement, the father's decision shall prevail, unless there is a judicial order to the contrary. Okay. So, in this case, it will now be the father's consent that will be respected, because in case of disagreement, the consent now of the father will prevail. So who do you side now with? Or which consent will prevail? Legally, it should be the father. So what is the recourse? You go to court. The mother will have to go to court, but it will be an exercise in futility. Okay? Because more or less, by the time, it will take months to years before this judicial order will be given. The patient or the neonate is already dead by that time. So that is basically the dilemma in this case. But take note of this. As doctors, we do not decide for the patient. Okay? We do not decide. Let them decide. If there's a conflicting consent, then let them settle it themselves. For us doctors, we do not decide for the patient. And of course, we never put an end to life. As I mentioned, we only allow one to die a natural death. It is always the patient or the nearest of kin, in this case, the father, whose consent will prevail over that of the mother, who will provide the consent. For us doctors, we only determine and explain all these appropriate means, but ultimately, what we have determined to be the most appropriate, the patient or the nearest of kin decides. In this case, it was the father's consent that will prevail. We just have to explain it, all the appropriate means, the pros and cons, the prognosis, the morbidity, and the like. But ultimately, even if what we have determined is the most appropriate management for this patient, the father and the mother who will jointly exercise will give the consent. Okay. Unfortunately, the father here has to, the consent of the father here will prevail over that of the decision of the mother. because as doctors, our primary responsibility is always to ensure that the consent of the father and that of the mother will be morally justified. It lies with the physician, how we explain it. That's why we have what we call the bioethics committee for this patient to be referred. Now, the termination of life, because one question here is the patient already dead? Is it brain death? Okay. The ascertainment of death is a clinical issue, meaning to say it will be the doctors, not for us lawyers to tell this, because this is not a legal problem. Dying is a continuing process. Death is an event that takes place at a precise time. And by law, when you say definition of brainstem, that is actually the irreversible cessation of circulatory and respiratory functions, or the irreversible cessation of all functions of the entire brain. So it will be the doctor who will have to declare if this patient is brainstem dead. Okay. For the parents again to decide. Now, what do we need to do with this patient, with this dilemma that the father's consent may prevail over that of the mother, and the mother wants to end it, but the father wants to continue. One basic factor that was not mentioned in this case is the religion of the patient. It was never mentioned in the facts of the case. Are the parents Catholic, Protestants, Islam, Hindu, or other religion? It was never mentioned. Because when we say bioethics, it refers to a certain religion. And I presume this is our bioethics in our country, and in this bioethics lecture, it relates to the Catholic religion. Of course, because this is Catholic Physicians Guild of the Philippines, so Catholic. But it was never mentioned in this case what is the religion of this patient, which is actually very, very important. Right of religion is a fundamental right. Right to treatment is only one of the basic rights of the patient, but right of religion is a universal right. So what do we need to do? We have to explain it again to this patient, discuss everything. Let the father come home if it is possible. With this age of technology, distance has been, there is no more distance, so to speak, when we try to get in touch with each other. Zoom meetings, there's so many applications now that we can use to have a full discussion of this case with both parents. Then refer this patient to bioethics committee, especially if the patient's parents are Catholic. We'll be having a problem if the parents are not Catholic, because the members of the bioethics committee must also have a member of their own religion. And when the time comes that there is now a joint consent, meaning to say the consent of the mother and that of the father is mutual already, we have to secure the proper consent. And assuming the consent is to withdraw everything, you also have to secure a consent for the removal of the ventilator or removal of all these medications. Because I would like for you to remember the example, the case I provided a while ago. Most ethicists will not be in agreement with me. I'm sure of that. In fact, all ethicists will not agree that the patient will be the one to remove the ventilator, to do the unplugging. But for legal purposes, for me, the one who consented for the withdrawal of all this support, whether medications or that ventilatory support or mechanical vent, the one who consent must be the one to unplug it. Otherwise, you run the risk also. The doctors will run the risk of being criminally charged for the crime of murder. Now, napakahirap. Most ethicists always tell me, it's so difficult for the parents to remove this. It should be the doctors or anyone from the medical or nursing staff. Now, for me, if they cannot do it, and you will let the medical or nursing staff to effect that unplugging of the ventilator, then another consent must be secured that the resident or the doctor or the nurse will be the one to unplug. And this should all be documented. Okay? So that when it goes to court, we have an evidence or proof, because what is not written in the medical records is presumably never done. And we just have to pray, not only for the neonate or for the patient suffering the same scenario, that they will have a peaceful death, but also for us medical practitioners, that we will not run the risk of being sued. Take note, suability is different from liability. We can easily be sued anytime. Suability, yung nadedemanda tayo. But for us to be held liable, it's very difficult, because if we have performed in accordance with good standard of medical care, then at the end of the day, we will not be held liable. But then again, as I mentioned, suability is totally different from liability. What we are always afraid of is being sued. Because we all know as doctors, if we treated the patient or managed the patient in accordance with good standard of medical care, we will not be held liable at the end of the day. And for that, as doctors, always remember this, in cases such as this case, that it is to cure sometimes, to relieve often, and to comfort always. Thank you very much, and have a nice day. Have a nice day to everyone.
So good day. I was asked to talk about the ethical end of life concerns in neonatal care. Una po, hindi naman ako doktor, hindi ako OB/GYN o pediatrician. I'm simply a bioethicist, a theologian, a moral theologian for that matter. But I did ask information from the OB/GYNs and pediatricians about neonate situations. And from that, the kind of care that they should be having. So first, what is a neonate? A neonate is a baby who is 4 weeks old or younger. The neonatal period is the first 4 weeks of a child's life, the time when changes are very rapid and many critical events can happen in this period. Feeding patterns are established, bonding between parents and infants begin. And most important, of important healthcare concerns, because this is a sensitive period, our concerns are the risks for infections. Infections may become more serious, and they are higher, and many birth and congenital defects are also first noted, which could lead to death or end-of-life situations. And so we talked about end-of-life situations. So decisions against the end-of-life care of neonates, especially those at the limits of viability, cannot be made on the basis of clinical facts alone. So we have books, we have manuals, what to do. But I'm very sure that when it comes to end-of-life care, it cannot simply be made on the basis of clinical facts alone. We should consider the values and beliefs of all those concerned. Applications of classical bioethical and moral theories may take insufficient account of the interests of small babies. So due consideration needs to be given to the value and quality of babies' lives, their best interest, and the interest of the parents in practical decision making. To begin with, in clinical ethics, there are a number of bioethical principles which identify key ethical values like beneficence, non-maleficence, autonomy, confidentiality, privacy, and justice. If you would notice, all these ethical principles would revolve around two persons, the parents and the baby. Now, these principles that we have mentioned provide a broad framework of ethical analysis in decision-making in the pediatric context, but they need some adaptation needed for a number of reasons. So why do we have to adapt? Because we have to take certain things in consideration. One, the child has no capacity for autonomous decision-making, cannot decide for himself. So parents will be deciding for the children, for the baby. Second, older children begin to develop cognitive capacities and life skills. And therefore, this would be a sign that they are beginning to develop their own capacity for autonomy. So therefore, if they're in this situation, it can complicate the principle of respect for autonomy. The well-being of the child depends on significant extent on the child's parents and the capacity to provide care and support. So this is another factor. Can the parents provide care and support? Financially speaking, psychologically speaking. And this is especially in the context of serious long-term condition, chronic illness, or disability. Now, as we have said, revolves around two persons. So here, the child is also a separate individual. So the child's well-being is not the same as the parents or the family's well-being. And D, children might have no sense of privacy. Now others, because of developmental skills, may want degrees of privacy. So these are the considerations that would complicate the application of the principles. Now, what are the general ethical principles in pediatrics? First, you promote the well-being of a child. So you have beneficence, you have non-maleficence. That is, number one, you have to act in any way that will benefit the child, beneficence. Number two, you have to protect the child from harm, that is non-maleficence. And protect the future related interests of the child, a combination of beneficence and non-maleficence. Now, the other side, you also have to promote the well-being of the family. And so you also apply the principle of beneficence and the principle of non-maleficence. And then, C, also the principle of respect for parents as decision makers of the child. And you invoke the principle of autonomy. In the same manner, you respect the child's development. And again, that is the principle of autonomy. Then you have to respect the privacy of the child. Then you have to respect the privacy of parents and the family. And then, of course, we cannot discount the allocation of resources at your disposal fairly. So these are the principles, ethical principles in pediatrics. Again, you have the bioethical principles and the principles in pediatrics. But again, let me tell you, even if you have all these things, it's not easy to decide in the end of life decisions for the baby. Let me give you certain instances. For example, what is the ethically correct thing to do when parents wishes to appear to be contrary to the child's best interest? So what is the ethically correct thing to do when parents' wishes appear to be contrary to the child's best interest? So, this is what the parents want, and yet somebody sees, or the doctor sees, this would not be for the best interest of the child. Now, before one decides, there are two things to consider. Who decides? Primarily, the parents. So the parents as decision maker. I am saying this, that parents' decision can sometimes be overridden. There are legal mechanisms to permit this, and there are ethical reasons why, in particular situations, the decision could be overridden. And even if legal steps are not taken, more subtle sorts of pressure can be extended on parents to change their minds. However, I like to emphasize there is not full agreement in ethics about what the situations are in, which is it ethically acceptable or even required to intervene and go against or change parental views. Because first and foremost, it would be the parents, no? So, the parents as decision makers. First, as decision makers, it can be interpreted as the parents as proxy. So here, the threshold of intervention is a decision that is not in the child's best interest. Parents as proxy decision makers for the child obliges them to make decisions which are in their child's best interest, that is, the decisions which best promote the child's health and well-being. The implication of this is that whenever parents' decision does not promote the child's best interest, then in theory, it would be ethically appropriate to intervene and override the parents. Sasabihin ng doktor in charge or ng committee, kung mayroong committee sa hospital, parang hindi ho tama. However, the decision to intervene is more complex. So, the parents as proxy. Then you have parental autonomy. So the threshold for intervention, so the parents intervene, is a decision that will cause a significant harm to the child. It is a less traditional view in which the parents' job is to make good enough decision for the child. So as parents, they have the obligation to consider the needs of any other children they have and the family as a whole. They also have the right to consider their own, at least to some extent, and to act on their own values and understanding of how best to raise and care for their children. So, it is a decision that will might cause significant harm to the child because the parents are not simply thinking of the child itself, but also of the interests of the family. Okay, so that is in terms of deciding. Now, we've said that you always decide for the best interest of the child. And therefore, you talked about the best interest principle. So what is to act in the child's best interest? So to act in a child's best interest is to do whatever will be best to promote all of the child's interest. It is doing the best for the child overall. Now, since the child has a range of different but important interests, it's not always possible to fulfill all interests all of the time. So for example, a child has interest in being pain-free and to live longer, but it may not be possible to have both. So therefore, as parents, acting in the child's best interest can be a matter of working out the best compromise. So what would be the best compromise? Or how to decide between considerations? So this makes judgments of best interest not a straightforward, factual matter. Reasonable people working on the same evidence can disagree, either because they have different views about probabilities, okay? Probabilities and positive outcome, or more likely, because they have different values. That is, they place greater weight on one sort of interest, that is living longer, than on another sort of not being in pain. So you have a child here, end of life situation. No, the child is what you call it. So sometimes the parents are caught between deciding, we would want that the child would not experience pain, no, and at the same time for the child to live longer. But sometimes that would not be possible. And so it's a matter of choosing what is ethical. If both are ethical, then you have to choose the best. Now, what about the parental consent in withdrawal or withholding of life-sustaining medical treatment? Now, there are some circumstances under which it could be ethically appropriate and even legally permissible for doctors not to provide some form of medical treatment, even if parents want the treatment and make an informed decision in favor of it. You know, in end-of-life situations for adults, there are principles that you follow, principles between ordinary and extraordinary way preserving life, no? And then you have a criteria for that. Is treatment futile? Is treatment not anymore will help the patient? Oh. But again, it could happen to a child. But the decision would be more complicated because the basic reason for this is that neither doctors nor hospitals have legal and ethical obligation to provide treatment which they believe is, number one, which could be clearly contrary to the child's best interest or causes the child's unjustified suffering. That is, treatments that would cause suffering and would only prolong life for a very short time before inevitable death. And the second would be because the hospital is such and is not within the hospital resources to provide. So meager resources, in terms of allocation of resources, the allocation is scarce. Okay. But then the main principle in terms of the child's withholding of life, withdrawal or withholding of life sentences is the fact that you don't deprive hydration or nutrition if the child still needs it. Because there are signs that would try to tell you the child rejects this already, and therefore it should be stopped. Or doing so causes more pain. So nutrition and hydration, even for inpatients, older patients, comatose patients that do not need any more aggressive treatment, nutrition and hydration should be continued as long as they're alive. Now, what about talking about futile treatment? So it says here, I'll repeat. The basic reason is that neither doctors nor hospitals have legal and ethical obligation to provide treatment which they believe is either clearly contrary to the child's best interest or causes the child's unjust suffering, that is, treatment that would cause suffering and would only prolong life for a short time. And it is not within the hospital resources to provide. Now, futile treatment. Futility is a relative concept. Whether or not something is futile can only be judged with reference to its goal. So when questions arise about whether treatment is futile, the key issue, therefore, is to consider the goal of treatment. You can only determine the futility in relation to the goal. As in the case, for example, of ventilators or artificial life respirators. The real disagreement is not about whether these ventilators or artificial respirators is futile, but rather about what goal is appropriate, or put differently, what outcome is worth aiming for. This is a difference in values, not a difference in facts. And it is not easily, as I've said, resolvable. Because when you talk of values, when you talk of beliefs, then many things differ. For example, Catholics would always adhere to the Catholic teachings of the Church in terms of the value of human life, the sacredness of human life that begins from the fetus in the womb and to a dying person at old age. Life would always be sacred. And therefore, if that is what life is, now when you talk of utility, when you use equipments like ventilators, what would be the purpose of that? What is the goal of that? For example, for a baby, is it to prolong the life? So you talk about the quality of life, no? Is it to prolong life only for 1 hour or 2 hours, and eventually the child would die? Or the goal is to revive so that the child would have the ability to survive later on when the ventilators and the respirators are withdrawn from the baby itself. So these are questions, no, that needs proper grounding and would cause a difference in values, not in facts. And therefore, it is not easily resolvable. There are many questions, again, no, in terms of how to care for neonates, no. But it boils down to the principle of healthcare. And what is healthcare? It is taking care of another's health as if it is your own. So that is healthcare. Taking care of the health of another person as if it is your own. Or if not, the other person becomes an object. The other person is not the same as yours. Then caring, therefore, would not be the same. Because when you talk of care, care is placing oneself in the situation of the other. And because when you place yourself in the situation of the other, okay, you feel what the others feel. You know what the other really needs. And when you respond to that need, then that in itself would be care. In terms of health, that is ethical care. Okay? So in other words, the ethical end of life concerns in a neonatal care is caring till the end. No? Caring till the end. That it is worth, that you can call it a life worthy of living, even for a child, for a neonate. So thank you very much for this short sharing that I have. And good day to all of you.
Thank you, Dr. Charito Corpus, Attorney Albert Rebosa, and Reverend Father Aligan. Just to summarize, end of life in the NICU requires holistic approach and consistent support of the family. It is necessary to develop plans to ensure that every neonate receives the best possible care regardless of the outcome. We now proceed with the question and answer session. To moderate this session is Dr. Fatima I. Jimenez. Our Q&A session moderator is Dr. Fatima I. Jimenez. Dr. Jimenez obtained her medical degree from the UERM MMC and her pediatrics residency at the Medical City. She completed her fellowship in infectious disease at the Philippine Children's Medical Center. Currently, Dr. Jimenez is the president of the Philippine Infectious Disease Society of the Philippines and serves as a training officer within the Pediatrics Infectious Disease section of the Philippine Children's Medical Center. She's also the chair of the Committee on Immunization within the Philippine Pediatric Society.
So good evening, everyone. Thank you for joining us tonight. I'd just like to acknowledge the three speakers. It is unfortunate that Father Aligan won't be here with us today for the question and answer, but we are very fortunate to have our two speakers in the persons of Dr. Charito Corpus. Chat, okay, is a very good friend. And of course, attorney, doctor, how do we say that? You know, I always have difficulty trying to put your titles together. Of course, we have, you know, the very famous attorney Rebosa with us. So let's start the ball rolling if it's okay with the two of you. And let's make this, you know, snappy and fun and very direct because we already have several questions and we were just given around 10 minutes. So chat, since you are the first one who got targeted with a question,
really?
right? Yeah, but let me
That
read it,
question.
okay? Let me read it. I'm extremely myopic, so I'm reading it from the chat box. Okay, so Dr. Hamtig, if the baby has been abandoned and is ventilator dependent or brain dead, who should be the one to decide regarding how aggressive the treatment will be or should be?
I think Attorney Rebosa already talked about that, yung
Yes.
hierarchy ng the ones who will give the consent. If all efforts have been put into looking for natural family and the long list of acceptable decision makers for the baby, and there's really none, then it's going to be the director of the hospital. Tama po ba yan, Doc? Attorney? Where the baby is admitted. So there's a legal procedure also to that.
If there's a DSWD in the hospital, then the DSWD must be informed so that they can provide the consent, which is the arm of the government for the welfare of the.
So it's the DSWD, not the director.
Well, on a legal point of view, I would rather that there is no consent signed by any of the doctors if it involves a legal implication. Because an emergency, actually, there is no need to provide a consent. There is no need for a hard copy of a signed consent if it's an emergency. What is important is it must be documented that there is an emergency so that necessary management will be provided. My dictum is that it's better to be sued for doing something rather than to be sued for not doing anything.
Yeah, so in that situation, the baby becomes like a ward of the state, or it's not equivalent.
Not equivalent.
So the DSWD henceforth makes or signs all of the subsequent consents that are necessary.
If they will sign, that would be better. But if they won't sign,
Yeah.
at least it was documented that the DSWD was informed of this case.
Okay.
The case for them.
Chat, let me just add to that. No? The question included how aggressive should the treatment be? So who will be deciding in that particular case? Now you know the hierarchy already. Who will be deciding how aggressive it will be? Let's say it's the DSWD. So I pose this question to the both of you. How aggressive? No? Because definitely the DSWD, I think, will not be equipped to decide how aggressive it should be. And on the legal end, you know, we're seeing or hearing Attorney Rebosa talking about, you know, the legalities of it, and you should not, right? Attorney, that is so helpful, you know, because we sometimes sign without thinking, right? So how will we resolve this particular question or this particular situation with regards to aggressiveness of treatment?
Well, if there's no one to give the consent, meaning to say this might be an abandoned baby or mother died and you cannot locate any next of kin, then the guidelines as provided a while ago by Dr. Charito Corpus, insofar as how to aggressively treat or not, would come. Meaning to say, as long as you did the standard of care and this patient died, then there's no problem. But as I've always mentioned, what is not written in the medical records is presumably never done. So in cases such as this, documentation is very important kung ano yung nagawa sa pasyente at yung ginawa sa pasyente is appropriate. Because we all know that there are extra appropriate or
Yes.
extraordinary means. If these extraordinary means are not done, it doesn't mean to say that we are negligent or we are incompetent to provide this. But because the standard is to provide the appropriate means. So yun lang importante. But if there is someone to give the consent, let's say how aggressive, then
Yes.
the consent of the father who gave us full aggressive measures, then we have to give everything within the means of the hospital, within the capacity of the hospital to provide this management.
Right. So I think I hope that Dr. Hamtig, okay, was able to gather very important points and the answers of both our speakers. All
Yeah,
right.
may I add to that,
Of
Timmy?
course. Yes.
Yeah,
Of course.
in most cases, actually, it's not an ethical issue. No? So for this particular case, all throughout, the parents or the mom at least was apprised no? about response or non-response to therapy as what is standard, and that actually is leading towards telling her that most of the therapies in place are the baby is no longer responsive to this, and this have to be explained to the parents. And this baby again in particular being on inotropes, for example, that's quite aggressive,
Aggressive.
right? And
Yes.
you already tell them because it's not within their capability to understand na ngayon po meron po siyang naririnig na heartbeat pero malakas po yung dalawang gamot na dumadaloy sa katawan niya. Ngayon, kung manghihina pa rin po, ibig sabihin mahina na po yung puso niya. So it's not actually like you're taking the matter away from something that they have to say yes to or no to, but explaining the medical condition itself takes a lot of burden away from them. It's actually as we say, no, allowing natural death if you are already at that point of irreversibility of the multi-organ dysfunction and all that.
Thank you, Chad. Attorney Ribosa, I think you did answer this question, but I'd like to acknowledge Dr. Arce. Okay, and probably if some of you were not able to hear it, okay, this is the question that attorney has already answered. If the baby is on ventilator and the family has decided to stop all support and medications after conference, who should turn off the ventilator, the family or the hospital staff? Attorney, I think you should be, if you could indulge us, and tell everyone again what you said, because it's super important. Yes, attorney.
If you ask us lawyers, the one who consented for the removal or unplugging of this ventilator must be the one to do it. Because of the possibility that if you unplug it, that's murder because you actually killed the patient. Okay. At the end of the day, you will not be convicted of murder, that's for sure. But murder is an unbailable offense. So we languish in jail while the case is being heard. So, but most often than not, when I get into discussions with ethicists, they wouldn't want the parents or the relatives to do it kasi nga ang sama na ng loob nila, tatanggal mo pa sa kanila. So ang device ko for this is that if the relatives or the one who consented cannot do it, there should be another consent allowing the nurse or the doctor or the resident to unplug it. So double documentation tayo. Okay. And it must be documented that they cannot do it. So I am now giving the authority to Dr. Ribosa to unplug it, and everything was explained. The baby will not survive. The patient will not survive. This scenario is not only limited to neonates. This is actually applicable to all end-of-life issues.
Right.
Yeah,
Thank
Timmy,
you.
may I add?
Yes, Chad, please, of
Syempre,
course.
I have to say something. Kasi,
Of course,
Yeah.
we were given
Yeah.
10 minutes, so let's
Yeah.
milk it for all it's worth.
Yeah, Attorney Rebosa, of course. I often retell this story because as a fellow, one of my mentors, I'm sure she's in the audience, Dr. Ching Rivera. No, when this question was posed to her, ay sabi niya, kung sino yung naglagay, siya yung magtanggal. I'll have to admit to you, back at the time when I was a fellow, and you have to understand the situation. You were going on duty every 3 days, and you have a baby that you need to bag manually, like every duty night, 2 to 5 a.m. So you're quite super bonded with a baby, just as what the moms and the parents would experience if they are really at the bedside at towards the end of life. It's very important again to explain the medical condition. And if there's some conflict in the decision of the parents, it's not a good time to do anything actually to withdraw any life support. But you also facilitate that they come to a consensus. And when they are at peace with the decision, no, yeah, we ask them actually to be with the baby when the act is going to be done. And hindi na po natin sinasabi na to unplug the ventilator sa ano po, sa pelikula lang po yun. We actually explain to them what's going to be done. And of course, if the scenario is just like in this patient, there's consideration of brain death, and that act will not actually lead to death of the baby, but we are allowing natural death, right? So we even explain to them, baby can be, you can hold your baby, we will make sure that the airway is clear. We can even give a little bit of oxygen so that they don't have to have this sense that we took away something. And pwede pong mangyari na pwede pa rin siyang huminga ng ilang beses, no? But importante na pareho kayong nandyan. So when the parents are both present then that's also like to me, that's an equivalent to another layer of consent to what you're about to do. And again, ano na po, it's not so, well, the experience is not really so bad. So that's the whole point of end of life care, to give comfort, as Dr. Rebosa said, always, no? Always to give comfort, even at that very painful moment in the lives of the parent.
You know, Chat, you said it beautifully, you know, and I'm being reminded of the times that, you know, there were situations when we were involved in a case that we had to give bad news. So I think this is the third and the last, but, you know, I wish we had more time, from Dr. Caparo. Okay, Dr. Rebosa, this is yours also. No? What's the hierarchy in terms of decision making? Number one, if the parents are unmarried, but the father recognizes the baby. Number two, if the parent is married, but legally separated. Three, mother is a minor. And fourth, mother died, I guess it's upon delivery, and father is present. So who decides?
Medyo mahaba. What's the first one?
The first one, yeah nga eh. So I think let's go to the premise that if there's like, you said something like, if there is like a, you know, non-congruent decision, it's the father who will always be the one, right? So in
if
this
they are
case,
legally married po, di ba?
Parents are unmarried, but father recognizes the baby. So there's that element of, you know, not being married. Does the father's decision still prevail?
In illegitimate child, the mother will always have the better right against the biological father, even if the biological father acknowledge the baby.
Okay, so
no marriage that will bind the mother and the father. The presumption is ang bata lumabas sa mami eh. Hindi lumabas.
Okay. So at least
will have the better right. Yeah.
Okay.
Now, if the mother is a minor, narinig ko ata yung
yes, the mother is a minor.
Mother is a minor, so definitely there is no marriage here, because it will be they cannot get married because one is minor. So we now have a mother who likewise cannot provide a consent legally because she is not of age of majority despite being conscious and coherent. So it will now be the maternal grandparents of the baby who will have to provide the consent for the neonate or for the baby.
Okay.
Of course, those consent must always be in discussion likewise with the mother. Kaya lang, if there's conflict, the maternal grandparents of the baby will have to their consent will prevail.
Attorney Rebosa, let me just tweak that a little. If it's the maternal, would it be, if the maternal grandparent disagrees, would it be the maternal, would it be the mom or the lolo who has the final say? Because, parang it was like, diba, father yung sa, in the legal sense. Yung grandfather ba, kung hindi nag-agree ang grandmother, ang masusunod?
We have this dictum in law that we have to, by analogy. So if the father and the mother, there is disagreement, then the father's decision will prevail. In the same manner, it is my opinion, I'm not saying this is the law for it, because there is no jurisprudence for this. Then it would be the grandfather who will, grandfather's decision that will prevail. Sometimes I get this questions on via phone.
Yes.
Dun mismo, during that time na nag-aaway, no? And I always tell them, pacify them. If the patient is actually dying, patagalin mo yung discussion nyo until such time that the patient will die. So we will not have any dilemma. The problem is, if the doctor is very good in maintaining the life of the patient, then it drags. Yun ang problema. Especially for young adults who have very strong heart but already vegetable, in vegetative state, those are the instances where it's very difficult to get a consent.
Okay.
Quick question lang, teams. So, Attorney Rebosa, so we don't have emancipated minor. Like, so if this, even if she's by age minor but she gave birth, so wala po bang ganun na emancipated minor, and she can make decisions for her baby?
I was actually anticipating that question. What about emancipated minors? Unfortunately, the decision, the definition of emancipation is above 18.
Okay.
So, kasi dati 21, bumaba sa 18 eh. So, the emancipation now, pasok pa dun sa 18 and above. Eh ngayon, age of majority is already 18. So, what's the difference between age of majority and emancipated? So, 14 years old, not emancipated, well, hindi rin siya of age of majority, because in some parts of the globe, like in the United States, different states, there is such thing as emancipated minor. Once they give birth, the mother will have to provide the consent. Unfortunately, it's still a gray area in our civil law, but definitely age of majority is the one of the legal requisites of a valid consent.
Okay, chat, thank you. It made my job a lot easier by making this discussion, very fluid. So
if we had longer time, we have more questions for Attorney Rebosa.
I know. So I think we need to let him come in again in another webinar. But Attorney Rebosa, Dr. Rebosa, and Dr. Chat, thank you very much. I'm sure a lot of people still have a lot of questions. So I think we need a part 2, but we'd like to thank you for your time and your expertise. I hope that each and every one of the participants tonight have a better or clear idea on how to handle ethical issues in end-of-life issues, rather. So with that, I'd just like to also remind the participants to please answer the post-evaluation survey. And for those who missed the initial parts of this program, the video will be available 3 days from now. So thank you very much, everyone. We will give way, for the closing remarks of the head of this team, the one responsible for the webinar, Dr. Mike Resurrection. Thank you, Dr. Rebosa. Thank you, chat.
Thank you.
Thank you.
Again, thank you to our brilliant speakers, Dr. Corpuz, Attorney Rebosa, and Reverend Father Aligan, and to our energetic moderator, Dr. Jimenez. We will now proceed with the virtual awarding of certificates to our esteemed speakers and moderator. Catholic Physicians Guild of the Philippines, Committee on Bioethics Module, this certificate of appreciation is hereby presented to Dr. Charito D. Corpus. As speaker, the ethical end-of-life concerns in neonatal care, given this 31st day of May, 2023. Signed, Michael M. Resurrection, MD, Chair, Committee on Bioethics. Sheila R. Yap, MD, Secretary, CPGP. And Ramon C. Severino, MD, President, CPGP. The same certificate with the same citation is awarded to Attorney Albert D. Rebosa, MD, and to Reverend Father Rodel E. Aligan, OP, and to our moderator, Dr. Fatima Jimenez. To formally close today's bioethics lecture series, let us welcome once again the Vice President of the Catholic Physicians Guild of the Philippines, Dr. Michael M. Resurrection.
Ethical decisions in neonatal care are guided by Hippocratic Oath and the principles of beneficence, non-maleficence, parental autonomy, correct medical facts, and justice. However, the complexities and uncertainties surrounding the neonatal care often makes this clinical decision ethically challenging. In behalf of the Catholic Physicians Guild of the Philippines, this is Dr. Michael M. Resurrection, saying thank you for the continuous support in our bioethics module. God bless everyone.